Welcome to the Deep Dive. Today we're tackling a really fascinating and surprisingly common medical issue that you might not have heard much about. Atheromatous embolization.
That's right.
It actually goes by a few other names too, like cholesterol embolization or Bluto Syndrome.
Yeah, and that's, part of the problem. It makes it tricky to recognize sometimes.
So this is our deep dive into this somewhat hidden condition.
Exactly. We're drawing from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. Really authoritative stuff.
Great source.
Our goal today is really to unpack this, explain what it is, what triggers it, the really diverse ways it shows up in the body, and how doctors try to manage it.
Okay, so atheromatous embolization. Let's break that down first. What's the core problem?
Well, in simple terms, it's when tiny bits of debris, mostly cholesterol crystals, break off from these fatty buildups inside your big artery.
Atherosclerotic plaques.
Exactly, those plaques. Think of your aorta, the main artery, like a pipe that's got some rough patches inside. Bits of that roughness, the plaque, can break off and travel down the bloodstream.
And they get stuck somewhere.
Yeah, they eventually lodge in much smaller blood vessels.
Yeah.
All over the body, potentially. And it's not just a blockage, they actually cause inflammation in those tiny vessels, too.
And because it can hit so many different organs and has all these names.
It gets missed. It often gets overlooked or misdiagnosed.
And this isn't a minor issue, is it? The sources say it's pretty serious.
Oh, absolutely. It's linked to a significantly higher risk of dying, both overall and specifically from heart or blood vessel problems. So understanding it better is really important for everyone, really.
So just how common is this?
Yeah.
You said it gets missed, which makes me think it might be rare.
That's a reasonable thought, but the numbers are.
Well, they vary. It depends how you look.
Okay.
If you look at autopsy studies examining bodies after death, they find evidence in maybe 0.2% up to about 2.4% of the general population.
Okay. Still doesn't sound that common across the board. But I guess it's different for certain groups. Precisely. If you focus on older folks, say over 60, who already have significant atherosclerosis, that hardening of the arteries,
Right.
the numbers jump quite a bit. More like 8.6% to maybe 12.3%.
That's a noticeable increase.
But here's where it gets really striking. Autopsies on patients known to have advanced atherosclerosis, especially those who'd had heart or major vascular surgery, showed evidence of these emboli in 22% to 27% of cases.
Wow. That's more than 1 in 5. And there was an even higher number mentioned, wasn't there, for a specific surgery?
There was. Patients who had surgery for an abdominal aortic aneurysm, that's a bulge in the main abdominal artery.
Right, the AAA repair.
In those patients, autopsy studies found signs of atheroembolism in a, frankly, staggering 77%.
77%. That's almost everyone in that group? Why so high there? Is it the aneurysm itself or the surgery?
That's the key question. It's likely both. The aorta in those patients often has really extensive fragile plaque.
Makes sense.
And the surgery itself, even when done carefully, involves manipulating that aorta, which can easily dislodge material. Plus, the plaques inside the aneurysm sac might just be inherently less stable.
Okay, that explains the really high number.
It's worth remembering, though, autopsy studies might find even tiny, clinically silent cases, so maybe a slight overestimation.
Right, compared to seeing it in living patients.
Exactly. Clinical studies where doctors are diagnosing it in active patients report lower numbers, maybe 1% to 4%, but that could easily be an underestimation.
Why is that?
Because the symptoms can be delayed, sometimes for weeks, and like we said, it's just not always easy to connect the dots and make the diagnosis.
So the true prevalence is probably floating somewhere in between those figures. What about looking ahead? Are we expecting to see more of this or less?
The sources suggest, well, potentially more. Our population is aging, and age brings more atherosclerosis.
That makes sense.
But on the flip side, surgical techniques, and especially endovascular, less invasive approaches, are getting better all the time. That might help offset the trend.
So, bit of a push and pull.
Yeah, we don't have really recent large studies to definitively say which way it's heading right now.
Okay, let's trace the journey of these cholesterol crystals. You mentioned they break off plaques. How does that process actually work? What's the pathogenesis?
Right, the pathogenesis. It was actually first described pretty well back in the 1940s. Flory was the researcher who linked it clearly to how bad the aortic atherosclerosis was.
Okay.
So the source, as we said, is those atherosclerotic plaques in the big arteries, aorta, iliacs in the pelvis, carotids in the neck.
And what are these plaques made of again?
They're a mix. There's a fibrous outer cap, immune cells like macrophages, dead cell debris, and the key component, cholesterol crystals, those waxy bits.
And some plaques are more dangerous than others. What makes them unstable?
Exactly. The ones we worry about most are often called vulnerable plaques. They typically have a thin fibrous cap covering a large, soft, lipid-rich core full of cholesterol.
So like a pimple waiting to pop.
That's actually not a bad analogy. They're much more likely to rupture. This can happen spontaneously, just from the stress of blood flow, or due to trauma, or, and this is crucial, during medical procedures that involve manipulating those arteries.
Like the catheterizations we mentioned.
Precisely. When that rupture happens, it spews out the contents, the cholesterol crystals, platelets, fibrin, which is a clotting protein, other gunk.
Into the bloodstream.
Into the bloodstream.
And these crystals, what are they like? Are they all the same?
They're typically white, and they have characteristic shapes under a microscope, often rhomboidal like diamonds or rectangular, little flat plates, but sometimes they can be more elongated, almost needle-shaped. Size varies, too, from incredibly tiny, less than 10 micrometers, up to maybe 250 micrometers. Still small, but big enough to block a tiny vessel.
And why do they get stuck where they do? You said small vessels, but why there?
Well, they're quite lightweight, and they tend to repel water hydrophobic. So they travel fast with the blood flow until the pipes get much narrower. That usually happens where arteries branch bifurcations, or in the really small end arteries, the arterioles, in places like the skin, kidneys, toes.
So they lodge there, and then what? It's not just a simple plug, right? You mentioned inflammation?
No, definitely not just a plug. The moment they lodge, they trigger an immediate inflammatory response.
Yeah.
The body basically sees them as foreign invaders.
The immune system kicks in.
Right. White blood cells rush in, specifically polymorphonuclear cells and eosinophils. That's the immediate reaction.
And over time.
Over the next, say, 2 to 4 weeks, it becomes more of a chronic inflammation. The crystals get embedded within other immune cells called giant cells, and also smooth muscle cells in the vessel wall. The lining of the vessel, the endothelium, starts to grow, and fibrous tissue, like scar tissue, forms around it all. This process can eventually block the vessel completely, obliterate the lumen, we say.
So the blockage causes inflammation, and the inflammation makes the blockage worse.
Exactly. It's a vicious cycle. And interestingly, even later, maybe 1 or 2 months out, sometimes the crystals can actually work their way out of the vessel wall into the tissue. Or they might stay trapped in a clot that formed. That clot might eventually break down a bit, maybe recanalize.
But the crystals themselves are tough.
Very tough. They resist breakdown by the body. They can actually hang around in the tissues for a long time, up to 9 months in some reports.
9 months? That's incredible. So these little irritants are just sitting there causing trouble for ages. And the bottom line for the organs?
The bottom line is tissue ischemia, not enough blood supply, not enough oxygen.
Okay.
And if it's severe or prolonged enough, it leads to infarction, tissue death.
And this whole timeline explains.
It helped explain why things like kidney failure, measured by serum creatinine, might not show up for weeks or even months after the initial event. It's not an immediate hit always.
Right.
And it also explains why recovery is often limited. It's not just clearing a simple clot. There's underlying damage and scarring.
Okay, that makes sense. So who is most likely to get this? What are the big risk factors?
Well, the number one risk factor, hands down, is atherosclerosis itself, particularly in the thoracic aorta running through the chest and the abdominal aorta.
The more plaque, the higher the risk.
Generally, yes. The severity matters. Other big ones are age, usually over 60, having existing coronary artery disease, peripheral arterial disease blockages in the legs, or an abdominal aortic aneurysm. Those are all strong indicators.
Anything in blood tests that might signal higher risk, like cholesterol levels?
There can be clues. A high ratio of LDL, the bad cholesterol to HDL, the good cholesterol, specifically a ratio over about 2.23, has been linked to having mobile or ulcerated plaque in the aorta. And that type of plaque is associated with embolic strokes.
So the type of plaque matters too, not just how much.
Absolutely. Plaques that stick out into the artery are mobile or are thicker than 4 millimeters. Those are riskier. Interestingly, plaques without much calcium might also be higher risk.
Really? I thought calcium was bad.
Calcified plaques can be more stable. The non-calcified ones are often those soft, lipid-rich, unstable plaques we talked about, prone to rupture. And these things called pedunculated plaques, like little polyps on stalks, they seem especially linked to recurrent, repeated embolization.
It really comes back to the health of the aorta, doesn't it?
It really does. Having complex plaques in the chest part of the aorta is usually a sign of widespread atherosclerosis everywhere else. It flags you as high risk for lots of cardiovascular problems, not just this.
Yeah, well, it can happen spontaneously.
Right, it can just happen. But often it's triggered, precipitated by some kind of mechanical stress or trauma to that artery wall.
Which brings us to the triggers. Our outline says endovascular procedures are now the most frequent cause. Why is that?
That's correct. These minimally invasive procedures using catheters threaded through blood vessels for things like heart caths or fixing leg arteries.
Stents, angioplasty.
Exactly. They involve physically moving catheters and guide wires around inside the aorta. That manipulation can knock debris loose. Even the forceful injection of contrast dye used for imaging can potentially dislodge plaque material.
Well, it still depends on the underlying plaque, right?
Oh, absolutely. The severity of the existing atherosclerosis is key. The more plaque, the more fragile it is, the higher the risk during any procedure.
What are the odds of this happening after these procedures?
The reported numbers vary. For cardiac cath, clinically obvious atheroembolism like seeing skin changes or kidney failure might happen in maybe 0.15% to 2% of cases. One study looking specifically for signs found it in about 1.4% after left heart caths.
And it's not just heart procedures?
No, definitely not. Procedures in other arteries carry the risk, too. And it's interesting these embolic protection devices, the little filters they sometimes use during stenting in the kidneys or carotids.
They catch debris.
Yeah, they frequently capture atherosclerotic material. It's proof that embolization is happening during these procedures, even if it doesn't always cause obvious symptoms.
So the filters show it's happening more often than we might realize clinically.
Exactly. One study looking at debris caught during carotid stenting, even in patients without stroke symptoms, found embolic stuff in 74% of them.
74%.
Yeah, and things like older age, existing brain lesions, the plaque characteristics they predicted who had more debris. There was even an older study suggesting that having had an arteriogram years ago might increase the risk of spontaneous emboli later.
What about open heart surgery? That involves the aorta too.
Yes, atheroembolism is a well-known and serious complication there. One autopsy study found evidence in about 0.2% of cardiac surgery patients.
Still relatively low, but serious when it happens.
Very serious. The effects can be widespread: heart, brain, gut, kidneys, legs. And in that study, death was directly linked to the atheroembolism in about 21% of those affected cases. It also means longer ICU stays, longer hospital stays, higher costs. It's a significant issue.
And other types of vascular surgery, like for aneurysms or leg blockages.
Also a known trigger. This link goes way back to the 1950s. Early autopsy studies after aortic aneurysm surgery, as we mentioned, found rates over 75%, contributing to almost half the deaths back then.
Wow. Techniques must have improved since then.
Definitely. The mechanisms are direct handling of the vessel, clamping, cutting into the artery. More recent studies show lower rates, maybe around 2.9% after surgery below the kidneys or in the legs, better techniques, more awareness.
And comparing open surgery versus stenting, say in the carotid artery.
Interesting point. MRI studies suggest that small embolic brain lesions might actually be more common after carotid stenting compared to the open surgery and endarterectomy. But the plaque characteristics seem to matter more for the stenting risk.
Now, this is interesting. Anticoagulation and thrombolysis, blood thinners, and clot busters as potential triggers. That seems backwards.
It does sound counterintuitive, doesn't it? And it's complicated and still debated. There are case reports suggesting a link where patients on anticoagulants developed cholesterol emboli and sometimes improved when the meds were stopped.
What's the theory there?
A couple of ideas. One is that the anticoagulant prevents a stable clot from forming over an unstable plaque, leaving it exposed to shed crystals. Another is that maybe the blood thinner causes minor bleeding within the plaque itself, destabilizing it.
But the evidence isn't solid.
Not really definitive, no.
Yeah.
Big clinical trials haven't consistently shown an increased risk with warfarin, for example. Some data even hint warfarin might be protective in specific cases, like with mobile aortic plaque.
So the current thinking is?
The current view is generally that if someone has a strong reason to be on anticoagulation, like atrial fibrillation to prevent stroke, the benefit usually outweighs this theoretical, unproven risk. It's likely safe to continue.
Okay. And thrombolysis, the clot-busting drugs.
Similar theoretical concern: could dissolving a clot expose an underlying plaque?
Right.
Again, there are some case reports linking them, but one small study looking directly at it found no clear relationship. So the evidence is pretty limited there too, not a strong link established.
Okay, so we've got the what, the how common, the how it happens, the who's at risk, and the what sets it off. Now let's get into how it actually looks in a patient. The clinical features. The great masquerader, you called it.
Exactly. Because the signs and symptoms are all over the map. It can be totally silent, asymptomatic, or it can cause huge problems: heart attack, stroke, acute kidney failure, mesenteric ischemia where the gut loses blood supply, major blockages in the legs.
And where it hits depends on where the plaque broke off.
Generally, yes. If the source is high up, like the ascending aorta or the arch, the emboli tend to go to the brain and eyes. If it's lower down, in the descending or abdominal aorta, it's more likely to affect the abdominal organs, kidneys, legs, feet.
And the legs can give clues, right? Both legs versus one leg.
Yes. Bilateral symptoms, both legs affected, usually points to a source high up before the aorta splits to the legs. Unilateral, just one leg, could be high up or further down in the iliac or femoral artery on that side.
And can be sudden or gradual.
Right. A big chunk breaking off can cause a sudden, severe event. But sometimes it's like a slow, steady shower of tiny microemboli, causing more subtle systemic symptoms that are harder to pin down. And remember that delay, especially with kidney issues, symptoms might not appear for up to 8 weeks after the trigger. Makes diagnosis tough.
Let's walk through the specific organ systems. The skin seems like a common starting point for clues.
Yes, skin manifestations are very common, often the most visible signs. Things like levator reticularis and Bluto Syndrome are classics, but again, they might not show up right away. One study found half the patients didn't get skin signs until over 30 days post-procedure.
Levator reticularis, describe that again.
It's that bluish-red, mottled, net-like pattern on the skin, usually on the buttocks, thighs, legs. It's caused by blockage of the tiny vessels deeper in the skin. Often looks worse when standing or cold.
And you can biopsy that.
You can, and finding cholesterol crystals supports the diagnosis. But levato itself isn't specific. Lots of things can cause it. You have to differentiate it from, say, normal mottling from cold or other conditions.
And Bluto syndrome.
Sounds dramatic. It is visually striking. Suddenly, one or more toes turn cool, bluish, and are often quite painful. Importantly, though, the pulses further down the foot are usually still present.
That's a key point.
Yes. The discoloration can also be patchy on the sole of the foot, and unfortunately, it can progress to ulcers, necrosis, tissue, death, even gangrene. You might see little lesions on the heels, too.
Are there other skin signs besides those two?
Yes, definitely. Things like splinter hemorrhages, tiny dark lines under the nails, petechia, pinpoint red spots, purpura, larger purple bruises, skin ulcers, sometimes painful purplish nodules that look a bit like vasculitis, even rarely ulceration on the penis or scrotum.
Okay, let's move to the kidneys. Second most common site, our notes say.
Correct. Kidneys get a huge amount of blood flow, and they're right downstream from the aorta, so they're very vulnerable. It's thought to cause maybe 5% to 10% of acute kidney failure cases in hospitals, but often goes unrecognized because of that delayed onset we mentioned.
And the mechanism is the same. Crystals block small vessels.
Yes. They block the arterioles and the tiny capillaries in the filtering units, the glomeruli. This causes ischemia, then inflammation kicks in with immune cells. Over time, you get thickening of the vessel walls, scarring, damage to the glomeruli and tubules.
And the way the kidney failure shows up can vary.
Quite a bit. Some people get a really sudden, severe drop in function right after a procedure suggests a massive shower of emboli. Catastrophic sometimes.
Okay.
More often, though, it's subacute. Kidney function just gradually worsens over weeks or months. That's the most frequent pattern and often needs a biopsy to diagnose.
Any other patterns?
Less commonly, it might present as just chronic, stable kidney impairment, looking like damage from high blood pressure or diabetes. And interestingly, a fair number of patients who initially need dialysis, maybe 20–40%, can actually recover enough kidney function later to come off it.
That's surprising, but good to know recovery is possible sometimes. Any other clues for kidney involvement?
Severe high blood pressure, especially if it's new or suddenly hard to control, is a big red flag. The kidney ischemia triggers the renin-angiotensin system, driving up blood pressure.
Right.
So resistant hypertension should make you think about it. And while recovery can happen, many do progress to chronic kidney disease or permanent dialysis. Factors making that more likely include heart failure, existing kidney disease, being over 70, having it triggered by a procedure, the faster onset types, having leg or gut involvement too, and diabetes. Statins seem to offer some protection, though.
What about the gut, the gastrointestinal system? Sounds like that's often missed too.
Very often overlooked clinically, yes. Autopsy studies show it's the third most common site, but it's diagnosed much less often during life. Probably because the gut has such a rich blood supply, small blockages might not cause obvious symptoms right away.
Where in the gut does it usually hit?
Most often the colon, then the small bowel, then the stomach. Less commonly, pancreas, liver, gallbladder, spleen.
Do those cause symptoms? Pancreas, liver?
Interestingly, finding emboli there on autopsy is common, but clinical pancreatitis or hepatitis from it is rare. Gallbladder involvement, though, while rare, tends to cause problems, inflammation, even gangrene.
So what are the typical gut symptoms people might get?
Abdominal pain is common, diarrhea, GI bleeding. The pain can be from ischemia, lack of blood flow, or later on from scarring and narrowing, causing strictures or blockages.
And the diarrhea and bleeding?
Diarrhea can be from inflammation, blood in the gut, or just poor absorption. Bleeding comes from ulcers, erosions, tiny infarcts in the gut lining.
Can you see this with an endoscopy?
Yeah.
Like a colonoscopy?
It's tough. The findings are usually nonspecific, just inflammation or ulcers. Sometimes biopsies might catch the cholesterol crystals, but not reliably.
And the gut is involved.
It often means the disease is widespread, involving multiple systems. And unfortunately, the prognosis tends to be poor, high mortality. One study of patients diagnosed via biopsy found most died within 3 months from related complications. They all had skin signs and kidney failure, too.
Okay, onto the central nervous system and eyes. These seem particularly worrying areas.
Absolutely. The consequences can be severe and permanent. For the eyes, the emboli usually come from higher up ascending aorta, arch, or the carotid arteries.
And the symptoms, vision loss.
Yes. Things like amaurosis fugax, so that temporary curtain coming down, vision loss in one eye, or more permanent blindness from retinal artery occlusion. The classic sign an eye doctor might see is a Hollenhorst plaque.
What's that?
It's a bright yellow shiny spot, actually a cholesterol crystal, lodged at a branching point in a retinal artery. Very diagnostic if seen.
Does finding that mean definite carotid artery disease?
Interestingly, not always. Studies show many with Hollenhorst plaques don't have significant blockages in their carotids. Survival can be okay, but there is a higher long-term risk of death from stroke and cardiovascular causes. The Blue Mountain Eye study confirmed that link to higher mortality, even though retinal emboli seem relatively rare overall in that population study.
And the brain itself, what happens there?
It can cause TIAs, mini-strokes, full strokes, confusion, altered mental status, headaches, dizziness, even a gradual cognitive decline, and organic brain syndrome. One autopsy study found generalized brain dysfunction, encephalopathy, was common, probably from lots of tiny emboli scattered everywhere.
Anywhere else in the nervous system?
Rarely it can hit the spinal cord arteries, causing paralysis in the legs. You really have to suspect it in an older patient, maybe after an aortic procedure, who suddenly develops kidney failure and becomes confused or unresponsive. Brain scans might show multiple small strokes, often in specific watershed areas.
And you mentioned it can really hit almost any organ.
Pretty much anywhere blood flows. The heart can be affected, causing angina or heart attack if emboli get into the coronary arteries. The lungs, rarely causing coughing up blood or shortness of breath, maybe from direct emboli or just the body-wide inflammation. Autopsies find them in the spleen, bone marrow, muscle, prostate, thyroid, adrenals, though often without causing obvious symptoms during life.
And sometimes just general vague symptoms.
Yes, things like fever, weight loss, headaches, muscle aches, non-specific signs that just suggest some kind of multi-system illness is going on.
Okay, with this huge range of possibilities, diagnosis sounds like a real challenge putting it all together.
It really is. That great masquerader label is well earned. The symptoms are non-specific. They overlap with so many other things. You absolutely need a high index of suspicion. Understanding all these different ways it can present is key to even thinking of it.
So often it's based on the overall picture.
A lot of the time, yes. Especially if you have a clear triggering event, like a recent procedure, combined with characteristic symptoms in multiple organs, and maybe those peripheral signs like blue toes or live do.
Are there any lab tests that nail the diagnosis?
No, unfortunately. There's no single blood or urine test that says, yes, this is atheroembolism. Labs mostly just show which organs are taking a hit. Elevated kidney markers like BUN and creatinine, liver enzymes, maybe pancreatic enzymes like amylase or muscle enzymes like CPK. That eosinophil count can be up sometimes in up to 80% of cases, but it's often temporary, so you might miss it.
What about inflammation markers?
Those are usually elevated CRP, ESR, fibrinogen. You might also see a high white blood cell count, maybe anemia, low platelets, sometimes low complement levels. Urine tests might show some protein or microscopic blood, maybe some casts, but nothing totally specific. Eosinophils in the urine are rare but suggestive if found.
What about imaging? Can scans help?
Well, first rule is generally avoid invasive tests like diagnostic arteriograms if you suspect this, because they could trigger more emboli.
Right, makes sense.
But non-invasive imaging can be helpful. Things like CT angiography, CTA, MR angiography, MRA, or transesophageal echo, TE ultrasound, through the esophagus to see the aorta better. If these show a really irregular, shaggy-looking aorta full of plaque,
That supports the diagnosis.
it supports it, yes. That shagginess on CTA has even been linked to stroke risk after certain aortic repairs. But big limitation imaging just shows the plaque is there. It doesn't prove that plaque is the cause of the current symptoms.
So if it's still unclear, how do you get a definitive diagnosis?
Often it comes down to a biopsy, getting a tissue sample.
From where?
Highest yield is usually from affected skin, especially an area of leafedo, or from the organ that's clearly involved, maybe tissue from an amputation or a kidney biopsy if there's new kidney failure, or GI biopsies if there's pain or bleeding.
And what do you look for in the biopsy?
The hallmark is those cholesterol crystals, or rather the spaces they leave behind. Standard tissue processing dissolves the crystals, leaving these characteristic needle-shaped empty clefts.
Oh, okay.
If you use special handling, like frozen sections or wet formalin, you can sometimes see the actual crystals. They look doubly refractile under polarized light and stain blue-green with a special Schultz stain. That's definitive.
Given how much this mimics other things, what are the main conditions doctors need to rule out? The differential diagnosis.
It's a long list. For kidney failure, you have to rule out contrast dye injury, or ATN, from just poor blood flow for other reasons. Then there are the vasculitis conditions, inflammation of vessels themselves, blood disorders like TTP, autoimmune things like antiphospholipid syndrome, even multiple myeloma.
Other sources of clots.
Exactly. Thromboembolism, regular blood clots coming from the heart, maybe due to atrial fibrillation or from an aneurysm elsewhere, or rarer heart sources like tumors, myxoma, or valve problems, endocarditis, bacterial or non-bacterial.
How do you tell it apart from vasculitis specifically, since both involve vessel inflammation?
That can be tricky. Labs like eosinophils or low complement aren't specific. You rely on the other clinical features, the skin signs, the pattern of organ involvement, and ultimately that biopsy. Vasculitis shows inflammation in the vessel wall, maybe destruction. Atheroembolism shows those crystal clefts with inflammation around them. Different picture.
And differentiating the kidney injury, you mentioned timing and urine sediment.
Right. Atheroembolic kidney disease urine is often fairly normal, maybe some blood. ATN or contrast injury usually has those dirty brown casts and kidney cells. Timing. ATN contrast hits within hours to days. Atheroembolism is often delayed a week or more. Recovery pattern. Better chance of recovery with ATN contrast if the cause is fixed. Less common with atheroembolism, though possible. And blood pressure. Often normal or low in ATN, but frequently severe and hard to control in atheroembolic kidney disease.
Okay, this is incredibly helpful in understanding the diagnostic puzzle. Now let's talk treatment. What can actually be done?
Well, the best strategy, especially thinking about surgery or procedures, is prevention.
How do you do that?
By screening high-risk patients before procedures, using those non-invasive scans, CTA, MRA, TE, to see how bad the aorta looks, if it looks really shaggy and dangerous.
You could choose a different approach.
Exactly. Maybe a different surgical technique that avoids manipulating the aorta as much. Or using careful techniques during procedures, gentle wire handling, maybe using arm access instead of leg access sometimes. And in things like carotid stenting, using those embolic protection filters or balloon occlusion devices is standard practice now to catch debris. Those studies haven't clearly shown one filter type is better than another.
Okay, but what if the embolization has already happened? What then?
Then treatment becomes mostly supportive care. Step 1. Avoid anything that could trigger more emboli. No unnecessary procedures.
Makes sense.
Then manage the consequences. Good blood pressure control. Manage heart failure if it's present. Dialysis if the kidneys fail. Make sure nutrition is adequate. Treat the symptoms in the affected organs, pain control, wound care for skin lesions.
And long term.
Long-term, it's all about aggressive risk factor modification. Statins, antiplatelet drugs like aspirin or clopidogrel, ACE inhibitors or ARBs for blood pressure and vessel health. These are crucial to slow down the underlying atherosclerosis and prevent future events.
What about specific drugs mentioned in the outline, like corticosteroids or statins?
Corticosteroids are controversial. There's information, so it seems logical, right?
Yeah.
But the evidence is mixed. Some case reports showed benefit improved kidney function, less gut or leg pain. But bigger studies didn't show a survival advantage, and one even hinted at increased mortality. So they aren't routine. Maybe considered in really severe multi-organ cases, but cautiously.
Statins.
Statins look more promising. They've been linked to improvement in skin lesions and kidney function. Retrospective studies suggest they might protect against recurrent emboli, possibly by stabilizing the plaques, making them less likely to rupture again. So definitely a mainstay of treatment.
Any other medical treatments?
Iloprost, a type of prostacyclin, might help with pain and skin lesions in the extremities or kidney problems, based on small studies. LDL apheresis, filtering cholesterol out of the blood, has shown some benefit for skin issues, maybe by improving blood flow or reducing inflammation. Other things like aspirin, dipyridamole, etc. have been tried, but lack strong evidence from controlled trials. Rivaroxaban wasn't better than aspirin for preventing secondary strokes in one trial, so really the cornerstone is optimal risk factor modification: antiplatelet, statin, ACE inhibitor, ARB. Now, sometimes if you can actually pinpoint the specific plaque that's causing the trouble and it's accessible,
You might try to remove or bypass it.
yes, surgical or endovascular therapy might be an option, but finding the exact culprit plaque is often hard.
What kind of surgery?
Usually thromboendarterectomy, cleaning out the plaque, or cutting out the disease section and replacing it with a graft. Surgery is sometimes seen as safer because you can clamp the vessels to control debris during the procedure. Some studies show good results from removing the source segment.
Any downsides to surgery?
Surgery on the aorta above the kidneys is riskier, and some think surgery should maybe be reserved mainly for severe leg ischemia from a source below the kidneys. For frail patients, maybe just tying off the leg arteries and doing a bypass can stop leg emboli but doesn't help the gut or kidneys.
What about operating on the chest aorta just to prevent emboli?
Generally not done for asymptomatic plaque risks usually outweigh benefits. It might be considered during other planned heart surgery. But surgery just to reduce stroke risk hasn't panned out and might even increase risk. So surgical removal is really for very select cases. Documented repeat emboli despite medical therapy, accessible source, low surgical risk. Endovascular options have also been tried. Things like clot-busting drugs directly into the artery.
Controversial, you said.
Right, might release more crystals. Atherectomy, scraping out plaque. Angioplasty, ballooning it open. Stenting.
Risks there, too.
Yes, angioplasty can fracture plaque and cause more emboli. Stents might provide a scaffold, but emboli can happen during deployment or even sneak through the stent mesh later. Covered stents with a fabric lining seem promising to completely exclude the bad segment. They've been used successfully in some cases, like for emboli from iliac arteries or AAAs, but mortality is still high in these sick patients.
What about those filter devices during peripheral procedures?
They're mainly used in coronaries and carotids. Off-label use in legs sometimes, but not routine, not always feasible depending on artery size, and maybe not cost-effective. Might be useful for really high-risk lesions during atherectomy, perhaps. We need more studies comparing endovascular versus surgical approaches here. And one crucial thing, especially with peripheral emboli, pain control.
You mentioned the pain can be severe.
Often excruciating, way out of proportion to how the tissue looks initially. Things like sympathectomy, blocking sympathetic nerves surgically or with injections, can sometimes help heal ulcers. Spinal cord stimulation has shown promise in some cases for rapid pain relief and improving blood flow. Getting pain specialists involved is really important.
This has been incredibly thorough. Let's try to summarize the big picture.
Okay, so atheroembolism is this multi-system problem, a complication of advanced atherosclerosis.
Often missed because it looks like so many other things.
Yeah.
Needs high suspicion.
Exactly. Treatment is largely supportive, managing symptoms, aggressive risk factor control. Sometimes you can treat the source, but often not.
And the prognosis.
Overall, it's often poor. That likely reflects just how severe and widespread the underlying atherosclerosis usually is in these patients. Prognosis does vary, maybe better if it's just limited to the legs versus involving kidneys or gut, but one-year mortality rates reported are stark, ranging from 13% up to over 80% in some series. Death is often from the underlying heart disease, strokes, or gut problems.
Which really brings us to a final thought for you, the listener.
Given that medical procedures can sometimes be the trigger for this really serious syndrome, what's the role for clinicians, and for individuals too, in trying to minimize this risk, especially as our population gets older and undergoes more of these procedures?
It really makes you think about both refining those procedural techniques and being much more proactive about managing those underlying atherosclerotic risk factors long before they cause such devastating problems.
Absolutely. It's a complex challenge that deserves ongoing attention from all sides.